Now we are in a stage where we are ready to teach the pain. So we should know, according to WHO analysis data, which all medication should be used and which are the conditions in which we have to use, etc. So it is important to understand the pharmacology a little bit. So today's session will be taken by Dr. Mary Abraham, who is a neuroanesthetist from Delhi, and she's a friend of Salim India. Presently, she is working as a consultant in many hospitals in Delhi, Max Hospital in New Delhi, then Lajpat Nagar, Indian Spinal Injury Center, as well as she runs a private clinic in Vasant in Delhi. She was awarded Lifetime Achievement Award by Neurology Association in 2017, and she has authored a book, and I would encourage all of you to buy and read this book, Conquering Pain. And um, she actually worked as a neuroanesthetist for many years, and she was an interventional pain specialist as well. And she also has an interest in pain and palliative care. So with this introduction, I welcome Mary Madam to this session, and it's over to you, Madam.
Thank you, Sunil, for that kind introduction and the nice words you told about me. And thank you, Shri Priya, for starting the session. And it's always a privilege for me to address so many people and communicate things on pain management to everyone. And I hope you all will take it forward and carry on with pain and bring relief to people who are in pain, particularly the cancer patients. So without, I'll just start with my presentation. Just 1 minute. So I will be talking about the broad outline of my talk will be on the basics of the WHO analgesic ladder, with a special focus on step 1 and step 2 drugs. Also, I will be touching upon adjuvant drugs and drugs for neuropathic pain. Now, coming to the WHO analgesic ladder, this was devised way back in 1986. It's been more than 30 years, but it has still stood the test of time. And even today, we are following the WHO step ladder, albeit with some modifications here and there, but the basic ladder we are all following. It has been translated into so many languages, 22 languages, and it's widely used to treat cancer pain all over the world. So it is a stepwise approach, because it's a ladder. So it is a stepwise approach. And before the ladder, that is before 80s, people were dying with unnecessary pain. Why? That was because there was a lot of drug regulations associated with the use of opioids, and people were hesitant to either prescribe it or even to take it. And there was a lot of stigma also used with this drug. People were said, even the relatives will say that my loved one will become an addict and there will be misuse of drugs. So all that led to a big hesitancy in taking opioids. But when the WHO introduced it, it actually legitimized the use of opioids, and subsequent to that, it's been widely used all over the world. So let me start with the case scenario. A 35-year-old father of 2 young kids. He had squamous cell carcinoma in the upper lobe of the right lung. The pain was a deep-seated, gnawing pain in the right shoulder with a burning and tingling sensation in the right arm. He was unable to sleep, and the pain score was NRS 4 during the day, but became 6 at night. This is a very brief, in a nutshell, I'm talking about this patient, right? So before we decide what drugs to give him, we all need to do a comprehensive assessment of pain, which I'm sure has been dealt with in the earlier lectures. So you can remember this mnemonic, PQRSSSTUV. Okay, That will give an idea about how to evaluate the pain. But in this, I will talk about one particular S, that is severity of pain. Because when you want to apply the ladder, it is important to know the intensity of pain or the severity of pain. Because that will decide how you escalate the drug. Also, it is important to know whether the pain is a nociceptive pain or a neuropathic pain, or is it a combination of the two, what is called a mixed pain. Okay, so that also is very important when you're applying the ladder. So if you look at the ladder, it is a 3-step ladder. Step 1, step 2, step 3. In step 2, it is for when the NRS scale is less than about 5. Okay, that means the pain is a mild pain in which you will give a non-opioid analgesic with or without adjuvant, depending upon whether there are other symptoms or other types of pain. If the patient is not responding to step 1, then you move on to the step 2, which is for basically an NRS in the range of 5 to 7, okay, approximately. And that is a moderate kind of pain, in which what you will do, you will add a weak opioid along with a non-opioid and with or without an adjuvant. Okay. But if the pain is not responding to this, or if the severity of the NRS is, pain is severe with the NRS of more than 8, then instead of a weak opioid, you will add a strong opioid with or without a non-opioid and with or without an analgesic. So that is the basic step ladder. Okay. Now, with this use of this ladder, up to 76% of cancer pains can be treated satisfactorily. So what are the salient features of the ladder? The first and most important, if you can remember 3 things: by mouth, by ladder, by clock, it will make things very easy. Okay, so what is by mouth? The oral route is what we use for all these WHO analgesic drugs. Okay, it's a standard route. Even for the strong opioids, you can give it orally. And the advantage is that it can be used for home care. It can be given by the attendant or by the nurse who's visiting, or if the patient is intelligent and able to understand, they can take it themselves also. So that is the first important advantage and the important feature of the WHO ladder. And the second is you go by the ladder. You can start from step 1 and move up the ladder if the patient is not responding. But if the pain is very severe, then you can directly go to step 3. So what you do is a opioid titration, and then you will you can start off with the step 3 drugs, that is a strong opioids. That will be discussed when you're doing the next class, which is the step 3 drugs. The next important characteristic is it's given by the clock. That means you have to give according to the duration of action of that drug or the half-life of the drug. So since the pain is more or less continuous, it is, if you can give it according to the duration of action of the drug, you will prevent the incidence of breakthrough pain. Because I have seen many times people saying that you take this morphine tablet 3 times a day. Now that is not suitable because the duration of action of morphine is 4 hours. So if you give 3 times a day, there's going to be a breakthrough pain that is happening. So this leads to peaks and valleys of pain rather than a continuous round-the-clock pain relief. So that will not, it will lead to a lot of anxiety and pain in the patients. You need to completely make them pain-free 24 hours, not in peaks and valleys, that kind of thing. So you have to give it by the clock, and that depends upon that particular drug. Whether it is a non-opioid or a weak opioid or a strong opioid, you go by the duration of action of the drug. So you have to be very clear to the patient that the first dose is taken at 6, then the next dose should be taken at 10, and then 2. So you can give the timeline so that it's easy for them to follow. The other thing is it should be individualized to the patient. So in one patient, as low as 30 milligram morphine can cause complete pain relief, but in another patient, you may have to give 300 mg of morphine. Both are right. The idea is that the patient should be relieved of pain. So if the patient has mild pain, they will require much less. So this also you have to tell them that in that particular duration, say in case of morphine, it is 4 hours. If there is a breakthrough pain, then what you should do. Okay, so all that is very much individualized to the patient. It can vary from patient to patient. The baseline is that you should get relief throughout the day. Then you have to add an adjuvant drug. So it depends upon the types of pain or other symptoms are present. So you may have to add an adjuvant drug to the WHO ladder drugs. And last is the attention to detail. Now, it is very important to see the patient and to monitor the patient, look for the side effects, look for the age of the patient and the coexisting diseases, and then you have to meticulously give the drug and meticulously monitor the drug also, the drug and side effects and etc. So all these are the salient features of the WHO analgesic ladder. Now, what are the advantages of this ladder? First of all, it is very simple, easily understood by anybody who are going to use this ladder. And it is also a validated tool. It has been found to be effective. And it is also very cost effective because most drugs of this analgesic ladder are relatively inexpensive. It can be implemented across the world, even in the lesser developed countries, very well suited for home care. It can also be given for acute pain or for chronic non-cancer pain. Like for acute pain is like when a patient has a fracture or the patient has got a post-operative pain. Even for that, you can apply this ladder. So besides cancer pain, you can even use it for other types of pain. Now, there have been modifications of the WHO analgesic ladder. Like instead of, you can, after step 1, you can directly go to step 3, or you can even add a 4th step because some patients do not even respond to the 3rd step drugs. So in which case you may have to add a 4th step to the ladder, which I'll just show you. This was a modification in 2000 in which the 4th step was added for that segment of patients who were not responding to the strong opioids. So what is the 4th step? They may be nerve blocks or epidural injections or patient-controlled analgesia, or you may have to give a neurolytic block using alcohol or phenol, or you may have to use intrathecal opioids or spinal cord stimulators. So these various interventions can be done as a 4th step of the ladder if they are not responding to the step 3 drugs. Now coming to the step 1 drugs. I said this is used for mild pain and maybe even moderate pain. And what are these drugs? They are paracetamol, also called acetaminophen, and the non-steroidal anti-inflammatory drugs. And they can be combined with the adjuvant drug. So paracetamol has predominantly a central action. It inhibits the enzyme cyclooxygenase or COX in the central nervous system. It has no effect on the peripheral COX. And because of that, the side effect profile is much better as compared to the NSAIDs, which acts on the peripheral COX. It has basically an antipyretic and analgesic action. It has no anti-inflammatory action. So what are the doses that we give? It is safe in a dose of 12 to 15 mg per kg every 6 hours. You can go up to 3 grams a day. It should not exceed 4 grams, and a single dose should be less than 1 gram. But the normal dose that we give is around 650 milligrams every 6 hours. There is also sustained release paracetamol tablets that are available that are 1 gram tablets in which 300 is given immediately and the remaining 700 is given over a period of time, is released over a period of time. So these tablets are also now available. You can also give paracetamol as an infusion, 1 gram every 6 hours. Rectal route may be used when the oral route is not feasible. Safe for pediatric use in a dose of 15 milligram per kg every 6 hours. Toxicity usually occurs in doses of more than 90 milligram per kg per day. Now, numbers needed to treat for paracetamol. Numbers needed to treat NNT is a very useful way to know the efficacy of an analgesic. So what is that? It is the number of patients who receive the drug for one to have 50% relief of pain for the next 6 hours as compared to a control. So the NNT of paracetamol, 650 milligrams, is 5. That means for every 5 patients, one gets relief of good relief of pain. So if you look at it, it is not as efficacious analgesic as some of the NSAIDs. I'll talk about the NNT of that later. So the main advantages of paracetamol are that it has a very good side effect. Very good safety profile. There is no adverse effect on the gastric mucosa, so it can be given for patients with peptic ulcers. It has no adverse renal effects, no adverse effect on platelet function. It's tolerated by 2/3 of patients who are hypersensitive to aspirin. It does not affect the plasma uric acid levels. But the disadvantages are that it should be given every 6 hours. It has no anti-inflammatory effect, and it has a potential for hepatotoxicity in high doses in those with impaired liver dysfunction, those who take excessive alcohol, whose body weight is less than 50 kilograms, where you have to restrict the dose to 2 grams. But even in patients with liver disease, doses up to 2 to 3 grams of paracetamol can be tolerated. So it's a mainstay of drug in cancer pain because of its good safety profile and because it has an opioid sparing effect. So when you add it to an opioid, you can actually decrease the amount of opioids you're giving. And it is given at every step of the ladder. It can be given at step 1, step 2, and step 3. And when you add it to an NSAIDs, the NNT becomes very good. It comes to 2. Okay, so that is one advantage of paracetamol. Now we move on to the non-steroidal anti-inflammatory drugs. Now, unlike paracetamol, which acts at the central cyclooxygenase, this acts on the peripheral cyclooxygenase. This is a very important enzyme in the arachidonic acid cascade after tissue injury, which ultimately produces a tissue prostaglandins, inflammatory prostaglandins. These are the important intermediaries. The prostaglandins are the important intermediaries for pain and inflammation. They act by a mechanism called peripheral sensitization, which leads to amplification of pain. And that is why this NSAIDs is particularly useful when there is a nociceptive pain, that is, pain due to tissue injury associated with inflammation. So if you look at this diagram that I've drawn, you can see that when there is a tissue damage, there is a release of the tissue byproducts at inflammatory mediators. These include bradykinin, prostaglandin, serotonin, etc. They form a sensitizing soup around the nociceptor, which is the peripheral nerve ending. And they cause an increased excitability and irritability of the nociceptor, which leads to the amplification of the pain signal. So the cyclooxygenase inhibitor acts at this level, the peripheral level. And it prevents, this is called peripheral sensitization. So it prevents the peripheral sensitization. The same thing you can see here. This is a peripheral nerve ending of the nociceptor. You have a tissue damage, the release of all these inflammatory mediators, and this acts at this level. So that is how the NSAIDs acts. So how does cyclooxygenase mediate pain? Now, whenever there's tissue injury, I said there's a release of phospholipids, which forms arachidonic acid, which is acted on by the COX-2 enzyme, which is induced by tissue injury and produces prostaglandins, which ultimately cause the inflammation and pain. But this is the harmful one. But there is also a good cyclooxygenase, which is called the constitutive COX, which is a COX-1. This is COX-2 and this is COX-1. This is important to maintain the homeostatic functions of the stomach and kidney and platelets. Now, when you give NSAIDs, both these enzymes can get inhibited. So by inhibition of this, you're decreasing the pain. But when you inhibit COX-1, it can actually cause adverse effect on the stomach, kidney, and platelets. Okay. Now, there are two types of non-steroidal anti-inflammatory drugs. The one is the non-selective, which interferes with both COX-1 and COX-2. But we also have a selective COX-2 inhibitor, which interferes only with COX-2. So it basically the beneficial COX-1 is spared. Okay. So let's talk about the non-selective NSAIDs. If you classify them, they can be aspirin, ibuprofen, naproxen, ketoprofen, diclofenac, piroxicam, ketorolac, indomethacin. They all come under the thing. Although diclofenac is functionally also a selective COX-2 inhibitor. So this non-selective, I said, is inhibiting both COX-1 and COX-2. And because it is inhibiting COX-1, it exerts the adverse effect, like GI side effects, hypersensitivity, and other adverse renal effects. But because it is inhibiting the COX-2, it has the beneficial effects of anti-inflammation, anti-inflammatory, analgesic, and antipyretic drugs. So the non-selective NSAIDs is a double-edged sword with both adverse and beneficial effects. Now, the examples, the prototypes of non-selective NSAIDs are ibuprofen, which has an NNT of 2. So it is a very good analgesic. That is, for every 2 patients, 1 gets relief of pain. And naproxen also can be used, which also has an NNT of 2.7. Okay, these are some of the NSAIDs that we are using in our practice. What the side effects of COX-1 inhibition? I said the COX-1 is the housekeeping or the constitutive enzyme. So when you inhibit the COX-1 because of the non-selective side effects, you can have the renal effects, the gastrointestinal effects, and the hypersensitivity. Now, but there's also a selective COX-2 inhibitor. They only inhibit the COX-2 enzyme, and the examples are etoricoxib, which is given only once a day in a dose of 60, 90, or 120 milligrams. It's called Nucoxia or Etoshine. Then you have celecoxib, which can be given 100 to 200 mg twice daily. And I said diclofenac can also be classified as a COX-2 inhibitor, where the NNT is 2. It is very good for very efficacious pain analgesic. Now, NSAIDs can also be given topically, which produces the analgesic effect with less risk of systemic absorption and toxicity, like gels and creams and sprays. Example are the ibuprofen, diclofenac, piroxicam, and ketoprofen. It can also be given transdermally. You have diclofenac patches of 200 mg. One of the brands that's available is U-Patch. So it can be given by other routes also. But are selective COX-2 inhibitors safe as compared to non-selective? When you look at the gastrointestinal effects, it can be safe. Okay, it is better than the non-selective NSAIDs. But where the renal damage is concerned, it's comparable. So it has no advantage where the renal side effects are concerned. On the other hand, it has a prothrombotic effect, which is a disadvantage. And it's more likelihood of producing a myocardial infarction and stroke. In fact, this particular COX-2 inhibitor, rofecoxib, was taken off the US market because of the incidence of thrombotic events. So when you have patients like that and you want to use an NSAID, then it is better to stick to the non-selective NSAIDs like ibuprofen or naproxen in the high-risk cardiac case. So if you look at the risk factors for NSAIDs toxicity, the GI toxicity, avoid in patients with GI bleeds and symptoms. Where the renal toxicity is concerned, again, advanced age, be careful. Dehydration, concurrent use of nephrotoxic drugs, and when the creatinine clearance is very low, avoid it. But when the stroke and MI are concerned, then the risk factors are diabetes, hypertension, hyperlipidemia, smoking, history of TI or stroke or angina. Then you should avoid using the COX-2 drugs. Now coming to the step 2 drugs. Now step 2 drugs, unlike the strong opioids, they are weak opioids. So they are not controlled, more easily available. And it is given for pain of moderate intensity, which is not controlled with the step 1 drugs. And the example that I will talk about are tramadol and tapentadol, because that is what we are using. So coming to tramadol. Tramadol is a centrally acting synthetic weak opioid. It has a dual method of action. First is because it's a weak opioid, it acts as a mu opioid receptor agonist. And because it's a weak opioid, it has less tendency for respiratory depression and addiction potential as compared to morphine. But it also has a non-opioid method of action, and that is by blocking, by blocking the presynaptic reuptake of serotonin and norepinephrine. So it acts on the descending inhibitory pathway of pain. And that is why it is effective for neuropathic pain, the second method of action. It is a prodrug, which means it's converted to active metabolites for its analgesic action by the enzyme cytochrome P50. And combination of tramadol and paracetamol are widely used as a step 2 drug. It has a high oral bioavailability, and its oral dose is quite potent. It's 1/10 as potent as morphine. So if you want to know the equianalgesic dose of tramadol and morphine, you have to divide it by 10 to know what is the equivalent of morphine. So how do you give it? In a dose of 50 to 100 mg every 4 to 6 hours. The maximum daily dose should not exceed 400 mg. And nowadays, even sustained release formulations of tramadol are available that can be given twice daily. Side effects, it can cause nausea, vomiting, dry mouth, constipation, sedation. There is a risk of seizures when the dose exceeds 400 mg, or when you give it with drugs that lower the seizure threshold, like TCAs or SSRIs, or when you give it rapidly IV. Okay, so you normally give it over a period of 10 minutes. Now, tapentadol, that is also a weak opioid, and but the recent studies show that it is almost equivalent to a strong opioid. Okay, so like you can see, 75 mg tapentadol orally is equal to 30 mg morphine. Now, the method of action again is similar. It is both opioid agonist as well as it acts on the descending inhibitory pathway, just like tramadol. It is not a prodrug, so it has no active metabolites. It has a better side effect profile as compared to tramadol, and the risk of seizures is also less, but you should avoid it in severe renal and hepatic dysfunction. The dose is very similar to tramadol, 50 to 150 mg every 6 to 8 hours, and sustained release formulations are also available. So if you look at combinations that you can give, never use two drugs of the same category. For example, you don't combine a COX-1 and a COX-2 inhibitor. Also, you don't combine a weak opioid with a strong opioid. Either you give tramadol or you give a strong opioid, but don't combine the two. And the combinations that are favorable are paracetamol with NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. They are the favorable combinations that will have a cumulative effect, and also it will decrease the side effect of the individual drugs. Now, let us switch gears and move on to neuropathic pain. Now, cancer pain is multifaceted. Okay, it is not just nociceptive. It can have a neuropathic element. It can have bone pain. There can be bowel obstruction pain. There can be pain due to muscle spasm, or there could be associated symptoms. In fact, 40% of cancer patients can have neuropathic pain. So the role of adjuvant drugs is for this to treat the other kinds of pains and the symptoms. Okay? So adjuvant drugs, the primary indication is not pain. Like, for example, an anticonvulsant is used for seizures, or an antidepressant is used for depression. But they have analgesic properties. So they are also called co-analgesic drugs. If you look at the classification of adjuvant drugs, you can base it. One category is multi-purpose drugs. That means they can be used for a variety of pains, like antidepressants, corticosteroids, or alpha-2 agonists. Then there are specific pains, like neuropathic pain, adjuvants for that, for bone pain, adjuvants, bowel obstruction pain, or musculoskeletal pain. So adjuvants are there for specific kinds of pains also. Now, if you look at this simple diagram that I drew, you can see that this is a nociceptor. This is where the tissue injury happens. So when cancer affects a particular area, this could be damaged. That causes what is called a nociceptive pain. Anything beyond this peripheral nerve ending along the peripheral nerve or in the central nervous system, which means the spinal cord and the brain, anything beyond this is called neuropathic pain. So neuropathic pain is caused by a disease or lesion in the peripheral or the central nervous system. But cancer pains can be a combination of the two. There could be a nociceptive as well as a neuropathic element. So you accordingly need to treat. Why does neuropathic pain occur? It can be due to a direct compression or the invasion of the nerve by the cancer, or it can be the treatment of cancer itself can cause neuropathic pain. For example, you have chemotherapy-induced peripheral neuropathy, where the peripheral nerves are damaged. It can be radiation-induced. It can be due to surgical excision, where the nerves are damaged, or it can even occur in cancer survivors. Much after the cancer is cured, permanent damage, nerve damage can cause the pain. So the pain may outlast the cancer also. So the first line treatment for neuropathic pain are the anticonvulsants. Why are anticonvulsants used for neuropathic pain? Because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal hyperexcitability, and these act by dampening the neuronal excitability. And the commonly used drugs are gabapentin and pregabalin. How do they act? Gabapentinoids, what they do is the calcium influx into the presynaptic neuron is prevented. Okay, so it acts to the voltage-gated calcium channels. And when this calcium influx is prevented, then the release of the excitatory neurotransmitter into the synaptic cleft is decreased. So this excitability of the postsynaptic neuron is decreased. That is how it acts. But besides the calcium channel, it can also act on the sodium channels and also acts by the GABA-mediated synaptic inhibition. The commonly used drugs are gabapentin and pregabalin. It has got a very good effect for neuropathic pain, but it has side effects like somnolence, dizziness, and fatigue and weight gain. And also, this has to be very, patient should be counseled that, you can be excessively sleepy, but usually in a period of time, they will get over it, but you start with low doses. If you compare the two, gabapentin is definitely less expensive, and this is more expensive, and this is easier to titrate as compared to gabapentin. Now, topical anticonvulsants are also, drugs are available for neuropathic pain. Topical gabapentin is available, and there's topical capsaicin, 8%, but it's not freely available in India. That can also be very effective for neuropathic pain. It's actually the pungent component of chili pepper, topical capsaicin. Now, the other drug, which is a first-line treatment for neuropathic pain, is antidepressants. This takes about a week for it to start acting, and the analgesic effect occurs even earlier than the antidepressant effects, and it even occurs at lower doses as compared to the antidepressant dose. So when cancer patients often have depression, anxiety, and insomnia, so they're very useful in these patients. How do they act? It acts on the descending inhibitory pathway of pain by blocking the reuptake of norepinephrine and serotonin. So the commonly used antidepressants in clinical use, the ones in black are the ones that we use commonly. That is a tricyclic antidepressants, the selective serotonin receptor inhibitor, that is SSRI, and the serotonin norepinephrine receptor inhibitor, that is SNRI. But there are other drugs that are also used for neuropathic pain. They include mirtazapine and some atypical antipsychotics like quetiapine, risperidone, or olanzapine, etc. But these are the ones that we are using more commonly. So if you look at the antidepressants, there are basically of three types. The tricyclic antidepressants, like amitriptyline and nortriptyline, the SNRI, which is duloxetine and venlafaxine, and the SSRI like escitalopram, citalopram, paroxetine, etc. If you look at the analgesic efficacy, the TCA is more potent than SNRI, which is more potent than SSRI. SSRI is mainly for the anxiety that these patients have. But the side effect profile is also more for TCAs as compared to the SNRI. Now, we should remember the side effects, the CNS side effects like somnolence and clouding and all, and the anticholinergic effects, which are dry mouth, glaucoma, blurred vision, tachycardia, urinary retention, constipation, and orthostatic hypotension. So you should avoid it in those patients who are susceptible to this. Okay. SNRI also can cause CNS side effects like somnolence, constipation, etc. And the contraindications for venlafaxine are those with hepatic and renal insufficiency, and duloxetine, you should be careful when there is hepatic insufficiency. These are the doses of the neuropathic drugs that we are giving. I think I have a little time, 5 minutes more, Shri Priya.
Yes, ma'am, please.
Okay. So always the thumb rule is start with a low dose and then slowly escalate. Okay. Like if I'm starting amitriptyline, I'll start with 10 mg and then every 3 to 5 days, you can increase it. You can go up to 50 to 100 mg also. That holds good for any of these drugs. And even for anticonvulsants, gabapentin, start with 100 mg and then you can make it 300 mg and you can go even up to 1200 mg TDS. But when you start with a low dose. Pregabalin also start with 75 mg, and I usually give it as a night dose because that means the sedation effect wears off in the morning, so they can carry on with the normal activities. But just remember, dose adjustment should be done for the medically ill patients and those with renal dysfunction and age also. Like an 85-year-old lady, I'll be very careful when I prescribe the drugs. Now, in this study, it was found that duloxetine, particularly in patients who undergo chemotherapy, it is quite useful to prevent chemotherapy-induced neuropathy. It is a randomized controlled trial, and they found that when you give duloxetine from weeks 1 to 5, there was lesser incidence of CIPN as compared to those treated with placebo. So the latest guidelines have suggested duloxetine for the initial treatment of painful CIPN. The other drugs that we use in neuropathic pain include, they are the second line and third line drugs. Okay. They include ketamine because ketamine acts at this NMDA receptor, which is situated in the spinal cord. So they can be given for the refractory neuropathic pains. But they have side effects like dysphoria, hallucinations. So you can add a benzodiazepine or haloperidol to decrease the psychotomimetic side effects. How do you give it? It can be given through a variety of routes. IV, IM, subcutaneous, oral, sublingual, intranasal, rectal, topical, intraarticular, epidural, intrathecal. Okay. The IM bioavailability is very good. It's 90% at 5 minutes. So ketamine is an anesthetic, but in a sub-anesthetic doses, it acts like a analgesic also. Okay. So when you're giving oral ketamine, you can give in a 10 to 25 mg TDS. You can give it as a subcutaneous or IV infusion of in a dose of say 50 to 100 mg per day. And then there is a burst ketamine infusion that you can use for intractable neuropathic pain. Okay. So that's called a pulse course of ketamine. So that can be used for the more refractory cases of neuropathic pain. Now, local anesthetics. They act at the sodium channels, and they're very good for neuropathic pain, particularly the severe intractable crescendo kind of neuropathic pain. How do you give it? You can give it as a local anesthetic infusion. You give in a dose of 5 mg per kg, add it in a 500 ml bottle of saline and give it over 1 hour with cardiac monitoring. So it is a daycare procedure. Also, topical local anesthetics are also available, like a 5% lidocaine patches are now available. But when you use it, just remember that you keep it for 12 hours and remove it for the next 12 hours because to avoid local anesthetic toxicity. The other drugs for treating neuropathic pain, like I mentioned, are topical capsaicin or topical gabapentin. So if you look at the neuropathic pain ladder, the first line treatment would be amitriptyline, antidepressant, anticonvulsant, duloxetine, and lidocaine patch. The second line of treatment could be opioids, particularly methadone and tramadol. And the third line would be baclofen, mexiletine, capsaicin, ketamine, etc. Now, coming to steroids. This is, like I said, a multi-purpose analgesic adjuvant drug. It can be used for neuropathic pain, bone pain, because of intracranial metastasis, for malignant bowel obstruction, and also for spinal metastasis. So of these, the drug that we prefer would be dexamethasone because it has a potent anti-inflammatory action. Just see, it is 25 to 50 times more potent anti-inflammatory as compared to hydrocortisone. And the other thing is it has a long duration of action. So it can be given every, its duration of action is 36 to 54 hours. So it need to be given only once a day. And because of all this, it has also got less mineralocorticoid effects. So less water and sodium retention. For these reasons, we prefer to use dexamethasone. But remember, they can cause insomnia, so give it in the morning. And particularly those with less life expectancy, they can produce short-term relief of pain and a general sense of well-being. Now, these are the doses. So I won't go into this. I'll just skip the slide. The other category is a GABA receptor agonist. GABA is an inhibitory neurotransmitter. So you have GABA A agonist and GABA B. GABA A includes benzodiazepines. Out of that, clonazepam is the one that we use for neuropathic pain. And GABA B is baclofen. Now, if you look at the neuropathic pain, the dose of clonazepam is 0.5 mg can be given orally, okay? Or you can even give in divided doses also. It can also be used for terminal sedation. Baclofen, I said, is a GABA B receptor agonist, and it can be used not only for neuropathic pain, but to treat spasticity, trigeminal neuralgia, and others. And it can also be given orally or even as a topical cream or intrathecal. It can be given even intrathecally using a pump. For bone pain, very agonizing pain, it affects the quality of life. The various drugs that are available include the corticosteroids and NSAIDs for multifocal bone pain, calcitonin, but latest review showed that there's no significant improvement in quality of life. But the bisphosphonates and denosumabs are the ones that are commonly used, and palliative radiation as well. Now, bisphosphonates, the one that we commonly use is zoledronic acid. It's given once every 3 to 4 weeks as an infusion, okay? But remember that can cause side effects like pyrexia, renal dysfunction, and osteonecrosis of the jaw. And if there's a decreased creatine clearance, then you have to reduce the dose accordingly. So denosumab is another drug that we're using, but it is more expensive. But it can be given subcutaneously with less risk of renal toxicity. And it is superior as compared to the bisphosphonates where the side effects are concerned and also where the efficacy is also concerned. But it is very expensive. The monthly cost of denosumab is 32,000, whereas zoledronic acid is just about 900 rupees. So it's patients need, affordability is a very important factor. Then these are the palliative radiation that we can use for bone meds. They include bone targeting nucleotides like strontium and samarium. Now, malignant bowel obstruction can also cause a lot of pain, and the various agents that are given are steroids, octreotide, and the anticholinergic drugs. Or you can even combine all the three. The other adjuvant drugs that we use include the muscle relaxants or the neurolepts, particularly when there's agitation and delirium, antibiotics, sedative, anxiolytics, and laxatives. So if you look at this pain pathway, this is a peripheral nerve ending. It's going to the spinal cord and to the brain. So you see the nociceptor, the drugs that act include the local anesthetic and the NSAIDs. And the NSAIDs are particularly important where the peripheral sensitization is concerned. The drugs like anticonvulsants and antidepressant opioids and NMDA act at the spinal cord. And for the descending inhibitory pathway, it's the drugs like the weak opioids, the alpha-2 agonists, the tricyclic antidepressant and SNRI. They act on the descending pathway, which is inhibiting the pain. So this is just to know where the various drugs are acting at which level. Now coming coming back to our case scenario. Now, I told you about this gentleman. How do we treat him? Now, what we need to discuss is what is the intensity of pain. He has a mild to moderate pain. What is the type of pain? It has got a neuropathic as well as a nociceptive component. Remember, he has got burning and tingling in his arm, which is a neuropathic aspect. Temporal nature of pain, it's worse at night. Unveiling the meaning of pain, there is a functional component, emotional component, social component, and financial component. So he's worried about his family and things like that. So keeping all this in mind, we would like to start with the WHO step 1 drug. We can add both paracetamol with an NSAIDs. We should ensure that it covers the night because the pain at night is worse. So maybe you can give a long-acting preparation at night, like paracetamol 1000 milligram or a diclofenac SR at night so that it can cover the night. You can add a neuropathic drug like an anticonvulsant and antidepressant. You can add an adjuvant drug like a sedative so that he gets good sleep, because when you get good sleep, the pain threshold actually increases. And then, of course, you have to provide psychosocial support for his financial and social concerns. So to summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management, can also be used for non-cancer pain, very simple, easy to implement, can be used all over the world, and above all, it has legitimized the use of opioids in cancer and non-cancer. I think, thank you for your patient listening. Over to you, Sunil.
Sunil sir, if you are trying to communicate something, you're muted. Sunil sir, do we have you? Not sure if there is a technical glitch happening over there. Anyways, I'm not, even though I'm not aware about the medical things, thank you so much, Dr. Mary Abraham, for this wonderful presentation. Yes, I think we have Sunil sir back. So,
Okay, so that was a detailed class on step 1 and step 2 meditations. So these are things we usually practice, but there are some things which we should know. So you can ask questions if you have any doubts. Dr. Reddy?
Good evening, sir. Am I audible?
Yes, you are audible.
It's a very wonderful presentation. I just want to know the drug of choice and the dose in CLD patients or in a patients with the high bilirubin levels to manage the chronic pain in such patients.
Okay. So it all depends upon the degree of the liver dysfunction that the patient has. Are the SGOT, SGPT and the other things also deranged or only high bilirubin?
Yes, ma'am. SGOT, SGPT is also deranged. And I think they're planning for the stent, for the intravalvular stent, but I'm not supposed that they're gonna plan anything because the treatment trajectory is like end of life care. We are not supposed is not for the best supportive care, but the attenders, the caregivers want to try something for the high bilirubin level raise. So currently the CPC score is in the between to B2C. The problem have got some the random report somewhere, and based on that the bilirubin is somewhat raised, and he's in encephalopathy grade 2.
Okay. So and what is the degree of pain that he has? Like what is the intensity of pain?
He has backache. It is 6/10. On X-ray, we have found out there is a bone metastasis, and the abdomen pain he says he is managed 3/10, 4/10. The abdomen pain. He is a CA pancreas patient with secondary lungs, secondary liver, and now he came with the backache, secondary bone.
Okay. So in such patients, you can use paracetamol, but cautiously. Like you can stick to less than 2 grams a day. Okay. And then other than that, if the pain is, you said it's moderate pain, right? What is the NRS in
Yeah.
this patient?
The abdomen pain is like 3/10, but he has backache like 6/10.
Okay. So in such patients, maybe you can add, low doses of tramadol. I think that is may not be contraindicated. And maybe you can try non-drug methods also. If he has backache, quite often it's because of a spasm in the back. And we can use non-drug modalities to treat that. Like in such a patient, since a backache is very bad, I would use dry needling for this, okay, which has no side effects. And it can cause a lot of relief in such, because patients with CA pancreas and pancreatitis, when the pain is radiating to the back, it is because of the spasm of the spinal muscles. And that can be treated by dry needling, which will have no side effects. So maybe a low dose paracetamol combined with dry needling would be good. Sunil, what is your take on this?
Ma'am, if tramadol is to be given, how much the maximum dose can be given to such patients?
Okay, like
Tramadol
normally
along with
tramadol
paracetamol.
maximum dose is 400 mg, but in this particular patient,
Yes.
I would say that you give half of it, 50 milligrams twice a day or 3 times a day,
Ma'am,
along with paracetamol.
we can add steroid also to this patient, no?
I'm not sure about whether we should add steroid for this, because
bone meds is there, lungs meds is there. It will act on both of that.
the back pain is it because of the bone meds or because of the CA pancreas that we have to?
Bone meds. He said bone meds.
Okay, in which case maybe steroid can be added. Sunil, what is your take on this?
Yeah. Paracetamol is actually not contraindicated even if patient has severe liver failure. So evidence says there is a systematic review which says up to 2 to 3 grams per day can be used safely, even in patients with liver disease. But so that's about a patient with severe liver disease. But if patient is having normal normal liver, and in such situation we can use up to 4 grams per day. And this patient, NSAIDs may not be advisable, but low dose steroids can be used because in bone metastasis there might be an element of inflammation, and maybe 2 to 4 milligram of steroid might be useful. And again, opioids, all the opioids, it might be metabolizing in liver, either by glucuronidation or by cytochrome B enzymes. So in severe liver failure, the doses of opioids need to be reduced. And methadone is actually not advised in patients with severe liver disease. So otherwise, you can use morphine, but not like 4 hourly. It might be used maybe 6 hourly or 8 hourly.
I think fentanyl may be preferred. If you look at the opioids, fentanyl will have less. Only thing is expensive, but
yeah. But I think even all the opioids, the dose need to be reduced. Both in liver failure, in liver failure mainly. And renal failure, some of the opioids may be used more freely than liver failure.
Okay, sir. Thank you, sir. Thank you, ma'am.
There is some question on fluoxetine. Can you explain a little bit about fluoxetine?
Where is that?
It's in chat box. What about using methadone and palliative external beam radiation to bone metastasis? Yeah, that's something which we need to consider. So Dr. Ravi Kiran is a radiation oncologist by himself. So I think he will be considering palliative radiotherapy for the bone metastasis also.
So we already planned for single fraction already because it's already in end of life care. So giving the patient for 10 days fraction is not much fruitful. The single day 8 grave per fraction is equivalent to the 5 days and 10 days. So we already given the single day fraction.
Madam, sorry. Do you know anything about flopiritin? Do you use in your practice?
No, I'm sorry, I don't.
Yeah, I also don't use flopiritin, but I know people promoting flopiritin, and it has some NMDA property also. That's what I believe, but I never used flopiritin in my practice. So I am unable to comment on flopiritin. Anybody else use flopiritin?
So I want to ask about oral ketamine. Does anybody have used it?
I think Sunil is using it, right?
Yeah, oral ketamine previously, I think oral ketamine is mainly used for incidental pain or people who have features of central sensitization. But now people is not favoring the use of oral ketamine due to many problems. But if it is definitely indicated, then only I will go for that. That means if a patient with central sensitization. Otherwise, I won't use. Even in patients with central sensitization, we usually use ketamine, either continuous subcutaneous infusion or continuous intravenous infusion.
Thank you, sir.
There is a question about whether de-escalating the drugs. So yes, definitely, if the patient is pain-free, we can slowly de-escalate the drugs. So it should be done again in a stepwise way and watch for the signs and symptoms. But many a time, cancer patients, they do survive. And I mean, they have a, they're cancer survivors. But if it's, like I said, chemotherapy, it may persist, but the cancer pain itself can decrease. So you can slowly de-escalate it. Just remembering that when you're using the opioids, it has to be done tapered off gradually because of the tolerance they develop. So there'll be a physical dependence. So for that, you need to de-escalate in a gradual way, taper it off.
Dr. Biju says it can be ketamine, some single ketamine can be used for bone debridement. Yes, it can be used, but now we have better medications than ketamine. So ketamine is not the favored one for such pain relief. It is more effective, morphine alone or combination of morphine and paracetamol orally in pediatric patients. Can you repeat the steroid dose slide, please?
Actually, combining, I mentioned that when you combine paracetamol with morphine, it has an opioid sparing effect. So you may be able to decrease the morphine that you're using when you're adding a paracetamol also. So we use it quite commonly, adding a paracetamol along with the morphine. Or for that matter, a weak opioid also, you can add it.
So she's also asking about your steroid slide.
Pardon me?
The slide on steroid, do you remember what you talked about steroid?
Yeah, but what is the question? What's the question?
Can you repeat the steroids slide, please?
Okay, then I'll have to start the share screening again. I'll do that.
Yes, ma'am. Please, just for the doses.
Okay, 1 minute. I'll just
Thank you.
start.
Thank you so much, doctor.
1 minute. Can you see it? Hello?
Not yet.
No. 1 minute. Am I able to do the share screening?
Yes, ma'am, access is already there.
Oh, then 1 minute. Sorry. I'm not able.
Ma'am, if you could tell the slide number, maybe I can try from here.
Just go towards the end.
Mhm.
My share screen is on, is it?
Yes, it is.
Then why am I not able to do it? I'm not able to do it. Sorry.
No worries, ma'am. I can do it for you. Just
You come right up to the end. Come right up to the end.
I'm just sharing the screen and then I will scroll as you say.
I think slide number 70.
Okay, now I got it. Now this is yours, no?
This is mine.
Okay, then please come right down. Right down. Yes. Okay, down, further down.
There is a slide
No,
delay in getting the screen. So from
come
this
down.
no, okay.
Come down. Further down. Now steroids, yeah. We are on steroids. What exactly you want to know? The dose, is it?
Yeah, yes.
Okay.
Okay,
So,
this one. Okay, yes.
okay. So when it's for bone metastasis, if the patient has only got a mild headache or the brain mets is a little less, then you can use in a dose of 4 to 8 mg a day, right? But when there is a severe rise in intracranial pressure, you can go even up to 16 milligrams per day. For malignant bowel obstruction, it is 6 to 16 milligrams every 24 hours IV. And then, then it can also be used as an appetite stimulant. Is this what you wanted to know?
Yes, thank you so much, ma'am.
Okay.
Thank you.
You'll get all this when you get the whole PPT. You can go through it.
Okay, thank you.
Okay.
So we have a class on opioids, and we will talk more about which opioids are more safe in hepatic and liver. And there is another question. In myofascial pain syndrome, NSAID or opioids to start with, if NRS is 7 to 8, some burning component is also there. Topical GABAergic with the baclofen will it be helpful? Madam,
Which is a question? What's a question that I need to ask about
myofascial pain syndrome?
Myofascial pain, believe me, they don't act. NSAIDs don't act and opioids don't act. It's very difficult to treat myofascial pain. Okay, and you can add a non-steroidal anti-inflammatory, try it out along with a muscle relaxant, but myofascial pain is not very amenable to treatment with these things. And for myofascial pain, I do either a trigger point injection or dry needling. That is what is going to be most effective. If there is a typical tender point or trigger point, you can give a trigger point injection and do a dry needling, which will be very good for myofascial pain, but they do not respond very well to opioids. We certainly don't give, but even non-steroidal anti-inflammatory drugs with muscle relaxant, you can try. It may be effective, but the other modalities will be more important, like
so we have a lot of questions on opioids, particularly about safety and step 3 opioids. So I think all those we will consider in the next session, where we have a detailed session on step 3 opioids. So I think um, Madam has given you a detailed note on various analgesics in step 1 and 2. And I think what you have to understand is regarding NSAIDs, there are more and more evidence are coming. And you also know that NSAIDs has a lot of side effects. So even on short term, it can produce, it can have side effects. So it is better that NSAIDs should be used when it is definitely indicated. So what is the definite indication of NSAIDs? It is inflammation. So don't give or once you prescribe NSAIDs, please have a review after 1 week, and if needed, continue for another few days. But never give prescription for long term, because it is going to be used not only by the patient, it is going to be used by the most probably by all villagers, because the neighbors is going to use for pain, and it is like that. So be careful while we use NSAIDs, and in patients with cardiac risk factors, patients with heart failure or something like that, or patients with the coronary artery disease, it is better to avoid all the COX-2 or selective inhibitors, like which are available are etocoxib or celecoxib. Literature says those are comparatively safer. That's why it is in the market. But still, it is COX-2 and two fearful side effects which can be produced by using or COX selective specific NSAIDs are stroke and myocardial infarction. So it is not advisable to give in patients with coronary artery disease or any other heart disease. So for those patients, it is the first choice is paracetamol or opioids. Then NSAIDs which are non-selective, like ibuprofen, and then comes NSAIDs which are preferential COX-2 inhibitors like diclofenac. So you have to understand that diclofenac is preferential COX-2 inhibitor. So it is more towards producing stroke or myocardial infarction if you use it in long term. So NSAIDs as a group has many side effects, and adjuvants, we know there are a lot of group of medications which can be used in specific conditions. So select adjuvants according to the presentation of the pain of the patient. And paracetamol is comparatively safer medication, and that can be continued long term if you want. But don't go for more than 12 milligram per kilogram if you are using continuously.
And also, we should never forget the psychosocial factors also. Like in that particular patient, he was, not getting sleep at night. So sedation, anxiety also need to be addressed, because we are focusing on total pain management, not just the physical pain, but we are also looking at the psychological, social, and the spiritual pain of the patient. So that is something that we should always factor in. Whatever the pain is, let us not have a tubular vision and look at the physical pain, but let us unravel the meaning of pain in that particular patient. And that can only be happened when you have a good rapport with the patient, you listen to the patient, look at the body language of the patient, and you can figure out whether it's just a physical pain or there are other things that are adding, and you need to treat those also, address those issues also. So the very, very common thing that I find is people are looking at the physical pain and not looking beyond that. Whether it is a cancer pain or non-cancer or even any acute pains, there is also these facets of pain that need to be addressed. Fear, anxiety, lack of sleep, so please address that to have a total pain relief. Neto, with just addressing the physical part, you will never be able to produce complete pain management.
Yeah, thank you, madam. That is a very important point because even now we have a patient admitted with us, a young lady. Actually, she has a non-healing diabetic ulcer, and she has a lot of psychosocial problems. So she was complaining of pain on both hip joint, which radiates to back of both the thighs. And when we did MRI, there was no much finding, like any disc collapse, which compresses on nerves. We couldn't see. So what we understand is she has a lot of problem which has started now because mainly financial problems. She had an NGO who was giving the rent for her house, and they were also helping her with education support for the son. They have now withdrawn the support, and now when we admitted and explored more, we could find out this, and our social worker could give some reassurance that we will be able to find out somebody, or else we can support them. So we didn't do anything or add any medication. She is on present medication, but with this reassurance, she is now having good relief.
Yes.
So the importance of psychosocial and spiritual factors on physical pain is something which we need to understand. When you experience, then only you will understand how much it can influence the patient. So with this, I think we will move on to the patient story, which will be presented by Dr. Nikhil.
Yeah. Good evening, everyone. I'm Dr. Nikhil Agarwal. I have a private practice in Gurgaon. And, So today is the case of a 66-year-old male. The case is like in a past time when during the February of 2022, when this patient was undergoing radiotherapy. The diagnosis was CA tonsil left side, squamous cell carcinoma T2N2, and he was having severe post-radiation mucositis. So as of 21st March 2022, the patient had moderate to severe pain and irritation in mouth, in palate and in throat area, almost whole of the oral gingiva, and the pain was almost continuous. The pain was much more increased while swallowing. Even if the patient was swallowing his own saliva, that was also quite painful, and patient was not able to take any diet. Solid diet was like totally not acceptable, and liquid diets were also very difficult to take. And patient also had difficulty in speaking and severe dryness of mouth. This is, as I told, is a patient of CA tonsil left side, and he was undergoing chemotherapy and radiotherapy treatment since 7th of February 2022. The patient was diagnosed in November 2021. Patient had completed 30 sessions of radiation. It was 5 sessions per week. So total 7 weeks was the therapy, and already 5 weeks were done. And the pain and other symptoms started after almost 10 to 12 sessions of the radiation, and they kept on increasing in severity significantly on each and every session. And the patient was provided treatment, but there was almost negligible relief. And right now the patient got into such severe situation that he wanted to quit the treatment. On examination, patient was conscious and oriented, and there was nothing significant in systemic examination. Oral mucosa was completely congested. There were ulcerations, and tongue was coated with white patches. It was candida, and there was foul breath. Then because of the radiation, the left side of the face and the neck was completely dark, and there was ulceration also. The gait was normal. Patient looked weak and sad, But when we talked to the patient said that he is not depressed as such, but the look on his face is because of the pain majorly. And the weight of the pain reduced from 65 to 60 kg because of impaired nutrition and the cancer treatment. In investigations, almost things were normal only. Hemoglobin and the counts were maintained. There was some neutrophilia, but not major issues there. Then sodium was constantly going down. Initially, it was around 134, 135, and 132, and later on, in the further course of treatment, it went even up to 130. And the potassium was sometimes high, but it was never in a high severe range, and other parameters were also maintained normally. Treatment was CTRT to tonsil with a dose of 70 gray for 35 cycles. So it was like 5 days a week was radiotherapy and once a week was chemotherapy. When you talk about the psychosocial aspects, the patient was financially very good, but because of his change in appearance and constant pain, he didn't want to talk to anybody, and he had difficulty in speaking also, and he didn't want to meet any outside person. So his social interactions were much reduced, and there was some sleep issues also. And but his personal family support and friend support system was very good. Everybody was very much helpful and tried to do whatever it could be done for him, which is like not very common with the cancer patients. They generally have bad support system, and financial issues are very, very common. And in general, before the cancer treatment started or before the diagnosis and even during the cancer treatment, patient was having quite strong willpower. It was majorly the pain factor which was causing some psychological problems to the patient. Then in usually, as we see with lots of cancer patients, they are worried about the prognosis and the outcome of the treatment, but he was not much concerned about that, but only lightly concerned about those things. And next, please. So during the treatment, medications were given. Pentop 40 and Domstal were in the routine chart. Supradin is an like multivitamin. For the pain, he was given paracetamol 650 mg 4 times. And because the meals were a concern, so it was advised to take 30 minutes before every meal. And Tramadol 50 was SOS. Patient was usually taking it twice a day. And Radiasoft cream was for the irritated area over the neck and head where there was some ulceration. And it was to be taken, it was to be applied 1 hour after the radiation sessions. Then Bestudent toothpaste was prescribed twice a day, but patient didn't had many teeth, and because of pain also, he was not using it regularly. Mucobenz gargle was even 10 ml in 10 ml of water every 4 hours. This was also asked to use before meals. And syrup mucin 3 TSF 10 minutes before meals. This was also given to improve the nutrition. And because of the candida, he was also given Forcan 150 and candida mouth paint. And Prosure powder was given to supplement the meals, as he was not able to take much of the diet. Next, please. So the main concern of the patient was moderate to severe pain throughout the day, which increased even while swallowing his own saliva, or even taking water or any of the liquid diets was also very painful for him. And dry mouth and thick saliva were other issues. Because of the thick saliva, swallowing of saliva was more painful. In summary, this was a 66-year-old male patient diagnosed with CA left tonsil, undergoing concurrent chemoradiation, completed 30 cycles, and presented with severe pain in oral cavity and difficulty in taking even the liquid diet. So the discussion points which I think are important is, was the treatment provided particularly for the pain correct or apt, or there have been more things prescribed to control his pain? second thing is, what more can we do or should we do for the pain management of this patient? And because nutrition was important aspect which was lacking because of the pain, how can we improve the nutrition in this patient? And for the nutrition aspect only, should we use nasogastric tube or gastrostomy tube in such patients? I mean, this will definitely increase the nutrition, but it also has some psychological aspects. So should that be used generously, or it should be kept only when it is absolutely necessary? And how to keep the patient motivated to complete the rest of the treatment? Thank you.
Thank you, Dr. Nikhil. So we have a 66-year-old patient who underwent radical radiotherapy and is having mucositis, candidiasis, and patient is having moderate to severe pain. So he has asked a lot of questions. If anyone has any suggestions or comments.
Sorry, I just want to add one more point is, during the treatment, I mean, I am a physician, I was not treating the patient, but the oncologist, they didn't want to start him on any of the morphine or any patch or any tube. Their preference was if the patient can complete the treatment with this much treatment itself. And there was no financial aspect was also not there. The patient was financially very well and he was being treated in a very reputed corporate hospital in Delhi. Thank you.
Thank you, Dr. Nikhil. So anybody has any comments?
Thank you, Mary ma'am, for that wonderful presentation. And ma'am, I'm Dr. Amrita from Talim, India.
Yes. Hi.
And thank you, Dr. Nikhil, for that wonderful case. I have a few comments on that. Of course, I understand that the patient was the oncologist there was not willing for step 3 opioids. Is that?
Yes.
Yeah. So, Dr. Nikhil, I have a few concerns regarding the swallowing difficulty that the patient has put forward. So, you have already reported that there are signs of candida infection in his oral cavity, but we don't know the extension of infection. Was there any chance of an esophageal candidiasis?
Esophageal examination was not done because of the ulceration in the mouth, but there was a possibility.
An oral antifungal?
Oral antifungal was given. Forcan 150 was given, and topical was also given.
Flucan was given.
Yes.
How was the frequent was it given, or the dosage, and how long was it given?
It was given for 1 week, Forcan 150, and local application was also used for around 2 weeks.
Once daily for 1 week?
Yes.
Okay. Still he had the same issue?
After that, after 1 week of that, candida resolved a lot, and then they also continued the topical application for 1 more week, like total 2 weeks.
Yeah, usually we give for 7 to 14 days in our setting. When we suspect the esophageal candidiasis, we go in and see how the response is there, and we try doing it for 7 to 14 days. And one another suggestion that I felt is regarding the optimization of step 2 opioid. Tramadol was on SOS basis, or it was taken only twice daily?
It was given SOS, but the patient was taking twice daily.
I have a suggestion that we could have optimized the dose of tramadol. It could have been given every 6 hourly.
Yes.
Yes.
Thank you.
I have a it's very good detailed presentation, Nikhil.
Thank you.
And very nicely presented. And of course, very relevant questions were asked at the end. And Amrita, thank you for your suggestions. So I was just thinking that along with the systemic drugs, what can we do locally for that patient? See, he has, according to you, you said there's a dry mouth. So that's
Yes.
a xerostomia. He also has a mucositis, and he also has ulcers.
Yes.
So the three components need to be addressed, So we can treat the dry mouth with certain things. We can treat the mucositis with certain things, and we can, the ulcer areas can be protected. We have mucosal protectors that are available. I think one is Gel Clear, which has something, it's called Gel Clear, I think the commercial name. But also after food, you can apply some paste on the ulcers, Carmelos paint. Maybe I can send all this on a thing, I will send it to Shri Priya, she can share it. Now for xerostomia, you can apply, there are saliva generators, saliva stimulants that are available. I think it's called e-saliva, and also pilocarpine. Pilocarpine can actually, by its parasympathetic action, it can increase the salivary secretion. That can also be applied locally for treating the dry mouth. Then for mucositis per se, you can either give this 10% lidocaine spray is available that can be sprayed on the mouth, or you can use 5% lignocaine ointment. But you can also use things like topical NSAIDs are available, like fluperitin. No, not fluperitin. Flubiprofen. Flubiprofen is available topically. It's available as eye drops, I know, but it can also be applied topically. That is topical NSAIDs. The brand is called, one is called Cool Benz. Cool Benz, COOLBENZ. The other one is Flubiprofen.
Okay.
That's a topical NSAIDs that can apply. And of course, for mucosal, there's another thing for mucositis. It's called a magic mouthwash.
Yes.
Sunil, you know about it, na? What
Yes.
all it contains.
So that sodium bicarbonate and water.
Yeah, it's a combination of this viscous xylocaine viscous 2%, along with antacids like what you mentioned, sodium bicarbonate, and also antihistamines. You can also add antibiotics and antifungals and mix the whole thing together. It's called magic mouthwash. Maybe you can Google it and see.
Yes.
So these are some of the ways you can treat the ulcers, the mucositis, as well as the dry mouth. All three need to be addressed. And you can use it topically along with the systemic things, because topical may be more effective in this patient as compared to the systemic.
Right.
Yes, Dr. Ravikiran, are you still there?
Yeah.
Dr. Ravikiran? Okay, as he is a radiation oncologist, I wanted to take his opinion. But Dr. Nikhil, why oncologists didn't want to use step 3 opioids? Any?
I don't have exact answer for that.
Hello?
Yeah, Dr. Ravi, are you here?
Yes, sir. I'm audible.
Yeah, do you have
Sir,
any
you got
comments?
muted. Dr. Ravi, yeah. Okay.
Hello, sir. Am I audible?
Yes, yeah.
Yes, sir. As Dr. Amrita Madam has said, that optimization of tramadol instead of SOS, it could be TID. And based on the pain regarding, we need to know, is there any neuropathic component is also been involved along with the nociceptive pain? And as such, most of the head and neck cancers, rather than step 3, with step 2 and the adjuvants, most of them can be run on a can continue with this most of times, which you can go for step 3 opioids, but step 2 to be optimized, that we can go for tapentadol as well. If tramadol has 2 to 3 hours or 1 to 2 hours, we can escalate to tapentadol and can manage with tapentadol with adjuvants as well. And in this, we can add neuropathic medications, what ma'am has said, the involvement of any neuropathic component also being there. And I think the counseling or the counselor, the psycho-oncologist plays a vital role in this regarding the man as the patient is being treated on curative lines. So the motivation should be very much and early integration of supportive care of all the teams, including the physiotherapist, the dietitian, the pain management consultant, the counselors will play a very vital role in these patients very much. And the opinion of the NG tube should be counseled because it's even difficult in swallowing saliva. The psychosocial, the domains of NG tube, some patients are reluctant. But if he's not, GJ tube is very permanent, NG tube is very temporary, so we can counsel the patient for the time being for to complete the treatment. So I think the early integration of supportive clinical services plays a very much vital role in this patient.
Thank you, Dr. Evi. This patient, did he complete all fractions of radiotherapy? Dr.
Yes, he completed the whole treatment. I mean, this was in March, and now patient is doing much better. He's still on oral diets only, but now his xerostomia is better and he's able to speak normally. And for diet part also, he's not able to move on to even semi-solids, but the liquid he is able to take very well now.
Okay.
And post radiation scans and everything is going good so far. Only he has some throat inflammation for which he is on azithromycin since a month or so. Post radiation.
Okay. Yeah.
Is there a burning component also for the pain? Is there a burning? Because like Dr. Ravi Kiran said, if there is burning and there are involvement of the nerves, then we must add an anticonvulsant also.
Okay. Burning component was not much significant that time.
Okay. What I understand is patients who are treated with radical radiotherapy for head and neck cancer, they are prophylactically put on either NG tube or PEG.
Yes.
Because people know that even before starting radiation, they are counseled that this are the side effects and this can happen. And for helping you, we are doing Wells tube or PEG, things like that. It is usually done. And I think if the patient is poor, usually Wells tube, and if the patient is affordable, they do PEG insertion. And according to ESMO clinical practice guidelines, they advise cryotherapy for 30 minutes for patients with radiation-induced mucositis. So according to WHO, there are grades from 0 to 4, where 4 is with severe ulcer and patient is unable to take any solids or liquids. And grade 1 is erythema, but the patient is able to take both the solids and liquid. So only evidence-based indication is cryotherapy. What we can do from our is that you can use ice cubes for keep it in mouth for some time, take it out. So that might be one of the things. That is one evidence-based point. And then local anesthetic like xylopine viscous, which is available, and you can ask the patient to swallow, keep it in mouth for some time, and then they can slowly swallow it. So that will give pain relief locally, as well as if there is something esophageal problem. Then I don't see any point, or if I have treated this patient, even if with step 2, if the patient has severe pain, I would have gone directly to morphine. There is no doubt about that, because every guideline suggests using WHO analgesic ladder for treating radiation-induced mucositis. This patient had continuous pain. In addition, he has incident pain when patient is following. So we can always use opioids for treating the pain. And how to keep motivation of the patient. I think we have to understand from the patient why he is reluctant to take further treatment. Because is it because during radiation he sustained this much side effect, and is it because of that, or is there something else that keeps him away from taking treatment? So that is very important to find out why he is reluctant. And according to, we have to talk to the patient. So we have to understand that whenever during treatment patients has problems or has side effects, they would be very reluctant. So it is our responsibility to treat any side effects proactively, so that they will understand that we are there to take care of them when they have some difficulties. So that's very important. And educating the patient is very important about what is the further treatment, and what is the role, and if it is not taken, what could happen. So all those things we have to explain. So those are something which I would like to add.
Okay.
And I think we have exceeded time, but thank you, Dr. Nidhi, for presenting this patient story.
I want to ask
Food generation. Yeah.
First question is, in this patient, like, should we, like, one thing is we should increase the dose or frequency of tramadol. Secondly, if we use the NSAID patch or add the oral NSAID, that will be a better approach, or to go to the morphine?
I think you optimize the dose of tramadol because maximum recommended dose is 400 milligram, which Mary Madam already told. But I think I would go for 50 milligram 6 hourly. And if there is no satisfactory relief with 200 milligram of tramadol, I would go to step 3 to morphine. And if you think there is some inflammation, then maybe NSAIDs can be used, but I think you need to be careful, because this patient is he is not taking fluids or diet properly. So he is already in a dehydrated status. So if you give NSAIDs, there is a chance of precipitating renal failure. So even with single dose of NSAIDs, you can precipitate renal failure. So I would be very careful while if I decide to give NSAID for this patient. As far as possible, I would avoid NSAIDs. But if needed, maybe I might give 1 or 2 days. Or yeah, that's what I would.
Second question is, does the use of cannabis help in such patients? I mean, it is not, I don't think it is much used here, but
cannabis, I don't have much experience, but I know that recently there was a I don't know, there was a review on cannabis for pain relief. But that study concluded that there is no much evidence for cannabis. So I won't go for cannabis at this stage, because I know that there are many other medications which will give you definite relief of
thank you, sir.
So thank you, Mary Madam, for being with us today, and as always, with the detailed presentation and clearing doubts, and for an excellent presentation. So thank you, and thank you, Dr. Nidhi, for presenting a patient story which generated a lot of discussion. And thank you, everybody. And I know there are many more questions remaining in your mind. And if you have something which is burning in your mind, Cypriya has created an Excel sheet where you can ask questions. And we will talk more about step 3 opioids in the next session. So thank you everybody for your active participation.
Thank you.
Thank you. Supriya?
Thank you, sir. Thank you, Dr. Mary Abraham. News are coming in that the Delhi is experiencing the coldest
cold,
weather,
yes.
and still you were very vibrant and energetic and took the talk so actively. Thank you so much for that. And please do take good care of your personal health as well. And thank you every participant for making this session interactive. And we do hope that this keeps on. This momentum keeps growing as the sessions progress. So with the promise that we'll be continuing the management of pain with part 2 in the next session. This is Sri Priya along with Dr. Mary Abraham and Dr. Sunil Kumar signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.